cancer doesn't begin as a tumour, it begins as a loss of control over a highly ordered system. In the normal colon, epithelial cells are constantly renewed. Stem cells at the base of the crypt divide, differentiate, migrate upward, and are shed within days. This process is tightly orchestrated by signalling gradients, especially the WNT/β-catenin pathway, which maintains stemness at the base and fades as cells mature. Cancer begins when this timing mechanism fails. In most cases, the earliest event is loss of APC, a key regulator of WNT signaling. APC normally degrades beta-catenin, preventing excessive growth signals. When APC is lost, beta-catenin accumulates and continuously activates genes that drive proliferation. Cells that should differentiate remain in a stem-like proliferative state, forming an adenomatous polyp. This is the starting point of the classic adenoma carcinoma sequence. APC loss creates opportunity, but not cancer on its own. Additional mutations layer on, each removing another level of control. KRAS activation locks in proliferative signaling, MAPK/PI3K pathways. TP53 loss removes DNA damage checkpoints and apoptosis. TGF-beta pathway disruption, for example SMAD4, eliminates growth inhibition and differentiation cues. What emerges is not random chaos, but clonal evolution, a stepwise selection of cells with increasing survival and growth advantages. Not all colorectal cancers follow this path. A distinct pathway, often arising from serrated polyps, is driven by BRAF mutations and widespread epigenetic silencing, CIMP. Here, key genes are turned off rather than mutated. When mismatch repair genes like MLH1 are silenced, microsatellite instability, MSI, develops, producing a hypermutated tumour rich in neoantigens and uniquely visible to the immune system. Across both pathways, colorectal cancer is defined by genomic instability. Chromosomal instability, CIN, leads to large-scale DNA gains and losses. Microsatellite instability, MSI, leads to accumulation of replication errors. This instability generates heterogeneity, fueling progression, metastasis, and treatment resistance. Tumours do not evolve alone. The surrounding microenvironment, fibroblasts, immune cells, vasculature, and even the microbiome actively supports cancer growth. Chronic inflammation sustains proliferative signaling. Fibroblasts remodel the extracellular matrix. Immune evasion mechanisms allow tumours to persist. In MSI-high tumours, however, this immune interaction becomes a vulnerability, one that can be therapeutically targeted.